I am Dr. Preeti Galgali, the co-chair of the IAH Education Committee. I welcome you all on behalf of the International Association of Adolescent Health and on the behalf of my co-host, Deanna, the host, Molly, and also Riza, the chair of the IAH Education Committee, who could not be here today because it's 3 a.m. in the morning in US right now. And she would surely be joining us for the next symposium. As we all get geared to look after 1.8 billion adolescents and young adults, it is imperative that we leave no one behind. To enable age and developmentally and culturally appropriate region-specific training programs, it is important to partnership with adolescents and young adults and also with each other. This is the first of the 4 sessions in which we want to stimulate international discussion about the best ways of educating and training professionals to deliver effective healthcare for young people. We have invited 4 dynamic health professionals to share their ideas and experiences. They will have 15 minutes to present, followed by 5 minutes for questions. Please type your questions in the Q&A box, and we will endeavor to get through as many as possible. However, if there is insufficient time, we will ask the presenters to respond after the session, and we will circulate the answers. We have circulated a program for the session containing a summary of each presentation together with more details about each presenter. The link of the program is there in the chat box. All sessions are being recorded and will be available after the event. Before we start, I would like to invite Professor John Klein, the president of IAH, to say a few words. Over to Dr. Klein.
Good morning, good afternoon, and good evening. I'm John Klein, the president of the International Association for Adolescent Health, and I am delighted to welcome you to this online presentation from our Education Committee. The International Association for Adolescent Health is providing today's program as part of our overall commitment to the call to action for adolescent health and well-being. The sessions are happening over the next month, and I hope you'll be able to join this one and some of the others to explore some of the issues in what we really need to do to improve the healthcare and the training of healthcare professionals to be able to meet the needs of adolescents in every country, for every family and every young person around the world. It's so critical that we improve access to care and that universal health care include the appropriate set of services for young people's needs. Whether it's mental health, sexual and reproductive health, or physical health care needs. The training of adolescent health professionals and the workforce that's needed to really improve the health of our populations is a critical part of that equation. And our Education Committee and many of our members are involved in addressing the standards and guidelines for training around the world. We need those standards. We need adolescent health experts able to help develop and maintain systems of education for primary care as well as for specialty care in every country in order to really improve the services that are needed. So thanks again for being here. I hope you'll explore some of the other upcoming activities that are being sponsored by IAAH and many other organizations as part of the Partnership for Maternal, Child, and Newborn Health, or PMNCH's commitment to adolescent health and well-being. And let me turn the program back over to our moderators and speakers to move on with today's event.
Thank you, Dr. John Klein. I apologize for the volume of the recorded video, but what Dr. Klein was saying was that it is so very important to develop adequate training programs for health professionals as a response to the call of action for global adolescent health and well-being given by the WHO, the PMNCH, the UNICEF, and many other global organizations. So let's start with today's symposium with the first presentation being given by Siska on the development of an online learning management system for adolescent health. Siska is a pediatrician teaching at the Faculty of Medicine in Indonesia. She's also the founder of the Indonesian Adolescent Health Association and has been awarded the Einstein Award from SAM for her work in adolescent health and training. Over to you, Siska.
Thank you so much, Dr. Preeti, for the introductions, and thank you for the Committee of Education of IWH for organizing this very important and exciting seminar. And of course, I would like to thank everyone participating in this first sessions of a series on innovations and updates in education and training in adolescents' health. So I would like to share my screen now. Can you see my slide? Okay, so as you may aware that I'll be speaking twice in this first sessions, at the beginning and at the end. I hope will not get you bored. And this is my first presentations on the development of an online learning management system for adolescents' health. So it is sore or in the afternoon in Indonesia. So selamat sore from Indonesia. A big country that lies around the equator line and consists of more than 17,000 islands. Yeah, and if you can see here, it's Bali. Bali is the most famous island, most famous for its tourism, yeah. But I can assure you that Indonesia has plenty of other places that equally or even more beautiful than Bali. So please come to visit our archipelago. Okay, enough for the tourism advertising. Indonesia has a very big inhabitants. It's more than 270.8 millions of populations, and like any other part of the world, a quarter of our populations is adolescents age 10 to 24 years old. And this is our adolescents health profile. I think like in many other parts in the world, it's especially in the developing countries, it's ranging from infectious disease such as TB, malaria, HIV, and non-communicable diseases, risky behavior such as smoking, drug use, multi-burden of malnutrition, teenage pregnancy. We still have a high burden of child marriage. At least 1/4 of our girls involved in child marriage, and we also had a great number of violence, bullying, injury, and other mental issues, and mental health issues. However, it's only there are 2/3 of our adolescents who do not have adequate access to health information, and half of our adolescents populations, they don't have adequate access to healthcare, as mentioned by Dr. John Klein in his welcoming remarks. One of the reason is because of the scarcity of the availability of the health service for the adolescents and its quality. Actually, Indonesia has adolescent-friendly health service since 2003 in public sector in the primary care. The number is growing up to 7,000 out of 10,000 primary health care centers until currently. But the number is very limited in the private sector, and especially most limited in the hospital setting. The significant challenge of these conditions is, of course, the capacity of the health workers, not only the healthcare providers, but also the health managers. So if as you can see here, so we do have some education and training around adolescents' health, both pre-service and in-service. But for pre-service, it's still very limited. Yeah, very limited. We will talk more about it in my and in my second presentations. And for the in-service training, actually our Ministry of Health had 2 weeks adolescent-friendly health service training for staff that provide service to adolescents in primary care in the public sector and the government-owned primary care, what we call and we call it Puskesmas, yeah, the primary care that owned by the government. But it has been stopped during the pandemic. We just restarted the training 2 weeks ago with a different format. So it has been roughly absent for more than 3 years. There are actually occasional seminar and workshop by related professional organization, but it is definitely not enough for a huge country like Indonesia. So last year, I developed the ramah-remaja.id. Ramah Remaja means adolescents friendly. It's an online platform. So I inspired by the Coursera.org, if you are aware of. So I would like to have, we would like to have an online platform, yeah, but specific for adolescents education and training for healthcare workforce that is accessible for any healthcare professionals across the country, across Indonesia. And it should be taught in, it should be conducted fully in Bahasa Indonesia, in our language. So that's why we come up with this online platform. In this big house, we already arranged 6 big rooms. Well, we can have more, but currently we try to arrange this in this big 6 big rooms. It's ranging from the basic adolescents health educations, and then communicable diseases and immunizations, non-communicable diseases, sexual and reproductive health, mental health, and daily common problems of adolescents. So in each big room, we can have several trainings in it. So until now, so it has been, this is our 2nd year. We already have 2 trainings. The first one is the behavioral change counseling for weight management training. And the second one is the basic adolescent friendly health service training. So I'm going to share you how we developed our first training on behavioral change counseling for weight management training. Actually, it is a part of my PhD project, and I would like to express my gratitude to Professor Susan Sawyer, the immediate past president of IAAH, who happened to be one of my supervisors for this project. And the training development consisted of 4 stages. The need assessment. The first stage is the need assessment. We did literal review and qualitative study on adolescents and their parents from 3 different sites. So the sites are the sites are different in social demographic backgrounds. And then from this need assessment, we draw the main themes to be able to find the learning objective and activities for the training. And after we have the list of learning objective and activities, then we started to develop the training content and training management guideline. Yeah. After this first stage finished, then we moved to the second one. We did a series of FGDs with adolescents health service practitioner, related professional organization, and the Ministry of Health to revise those documents. And then after we got the revised document, we did the initial pilot to National Facilitator of Adolescent-Friendly Health Service. And then we revised again the documents, training content, and training management guideline. And then we had the national scale pilot with 64 primary health workers to have the finalized training. And this is how we draw the learning objective from the theme. So from the qualitative study that we did in 3 provinces, we have these 4 big themes, yeah. Limited knowledge of healthy lifestyle. Healthy lifestyle is not a primary daily concern, availability and accessibility, and also limitation of parenting skill. And from each themes, we translated to a learning objective. So for example, the themes number 1, limited knowledge and of healthy lifestyle, we translated into 2 learning objectives. Because there is a need of more knowledge on healthy lifestyle, then we need to make sure that our participants in the training would have a better understanding about adolescents' growth and development, and also healthy eating behavior and physical activity that is recommended for adolescents. Second, the theme that healthy lifestyle is not a prominent daily concern. It means that we need to make sure that the participants of our training could, raise or invite internal motivations from the adolescents, patient, and the parents. So we put the learning objective, 2 learning objectives that to understand the behavior change concept and the principle of motivational interviewing and how to perform it and how to conduct it, and so on. So finally, we have 7 learning objectives from the themes that we obtained from the qualitative study that we done. And then we work on the learning activities. Yeah. Beside the need assessment and in the literature review, we use the Walsh and McPhee theory. In this theory, they mention that the most factors that can help professionals to perform better in their counseling service is whether they have interest, is how is their self-efficacy, and their self-conception about their role. So to address these 3 issues, we decided to have an active learning method during the training. Apart from this active learning method, we help the participants to develop self-habit identifying, self-behavioral change planning, and physical environment mapping. And then after we had that list of learning objectives and learning activities, then we developed the training documents, consist of training content material and training management guideline. And these all were discussed with all related professional organizations and the Ministry of Health. It was a collaborative work among pediatric nutritionists, sport medicines, and clinical psychologists. And we were so lucky that we received some credit point for the training from the Indonesian Medical Associations and from the Indonesian Nursing Association. And this is how the trainings flow chart. Yeah, it's a 4-week training. So at the beginning of the training, we required participants to record 2 counseling sessions with real adolescents, their own adolescents patients, to the system. Yeah, and then they need to learn from the videos that are already available in the website. Yeah, for every week there are videos available related to the respected topics for that week. And then after that non-synchronous learning, so independent learning, watching videos, they can get the link to join the Zoom meeting. Yeah, so only if they finish all of the videos, then they can get the link of Zoom meeting. In the Zoom meeting, the synchronizations, we only have a group work and group presentation. So there is no presentation at all from the facilitators. Yeah, the group work and the presentations was done according to the learning topics for that week. After the synchronous Zoom meeting, then they will assign to do some homework. Yeah, there are quizzes, virtual case exercise, and also some written assignment that they need to submit to the system. And after they finish everything, they need to do another counseling with the same adolescents, yeah. So they can we can see the difference between before and after the training. Only when participants already submitted the recording sessions and the assignment, they will get their certificate. And all of this development of this training, we use constructive alignment theory, which means that we emphasize the alignment between the learning objective, the learning activities, and also the assessment of the training. This is how we arrange the website, the training within the website. There are 4 main topics, and participants can only do like the second topic after they finish everything in the first topic. You see, so they will get their certificate if they finish everything. And this is how the training material looks like within the website. We have video presentation, video explanation, quizzes, virtual case game, and of course, online counseling videos. And this is the Zoom meeting that we had last year. Since it was a national pilot, so Ministry of Health provided the opening remarks. And as I mentioned before, we only had the group work and group presentations during the Zoom. And of course, during that 2 or 3 hours Zoom, we have break in between, and usually we made some dance, yeah, together with the participants, yeah, to release our, to move, yeah, to be in line with the, healthy lifestyle that is highlight in this training. So within the website, we have participants and facilitator side. So both sides have different role, have different function. In the participant side, the participant can see the all the training materials and can see their completion progress. Meanwhile, in the facilitator side, of course, we can see all the editable training material, and we can see the whole participants' completion progress and also individual completion progress. Besides that, we also develop the assessment tool, yeah, to see and to be able to provide individual input, yeah, for the participants. We have both quantitative and qualitative assessment. For the quantitative, we develop a validated rubric assessment, and so there are scores, yeah, between 0 to 100, and for the qualitative, we can provide strength and room for improvement for each counseling session. So every participant can have this feedback, both quantitative and qualitative, through their personal account in the website. So
this looks like an exciting program. Could we just have the summary points? Thank you so much.
Yeah, thank you. This is the nationwide pilot, 64 participants from 70 provinces. And this is the training completion rate. We have 72 to 72 progress completion rate, and attendance rate is 78%. And this is, I think it's quite a high participation and completion rate because we did it during the Omicron was reaching its peak in Indonesia. And this is a training process evaluations. We got 5.3 out of 6 Likert scale for content clarity and attractiveness of the different methods. And qualitative, we got some very positive comments from the participants. But however, we do have some issues. First is the digital literacy level of participants. Some participants do have some problems in opening their account, uploading recording, and assignment. And also we have some problems with the internet signal, especially those who from the remote area. And the solution, we provide personal explanation and a backup email provided. So when they have a problem in uploading the recording or assignments, they can just send it to the email. Q&A, we also provide Q&A folders with step-by-step pictures, and the resolution of the videos were all downgraded to the lowest one. The similar is it's really a similar finding with systematic review for internet intervention in developing countries. And the second training development, Basic Adolescent Health Service Training, is an online application on offline training. So it was a 3-day offline training on basic adolescent friendly health service with these topics, and it's also a collaborative work, and it's funded, the pilot was funded by UNFPA in 2019, and currently we try to translate it into online translations. This is how the online translation looks like. It's still under construction, but for each sessions, we already got the videos and reading materials for each topics. And this is the development stages that we plan. And I would like to express my gratitude also for Sam through the Nansen Award who fund this project. We did the initial online transition did the first pilot. Now we are in the development of training content and training management, the revising training content and revising training management guideline. And we hope to do the FGD at the end of this year. And at the end of the stage of this second training, we would like to register this training to the National Training Registry Platform to make it a compulsory training for all health professionals that provide service to adolescents. And the fourth visual development, surely we will finish the second training development and conducted regular training in collaboration with the Indonesian Association for Adolescent Health and the School of Medicine of Universitas Pelita Harapan. And we have been trying to invite other university and other organizations to build an online training of other adolescent health topics with RamahRemaja.id. I think that's all for my presentations. Thank you so much for your kind attentions. I give back to Dr. Preeti. Thank you.
Thank you so much, Siska. That was a wonderful presentation, and I'm sure each and every person on this platform would be keen to know more about this program of yours. We request all of you to please put your questions in the Q&A, and Siska will be very happy to answer these questions. And we move on now to the next presentation, which is on a different training model for adolescent medicine, the PhD program at a university in Ankara, Turkey. And this presentation would be given by Professor Sinem Akagu and Dr. Melis Kajulka. They are both from Ankara. Dr. Sinem is a professor in the Division of Adolescent Medicine and also the program director of Adolescent Medicine Doctoral Program, and she is the vice president of the Turkish Adolescent Medicine Society. Dr. Sinem is and Dr. Melis, is the associate professor of pediatrics and the co-chair of the IAH Early Professional Network. We are so happy that you could join us today. It is the platform to speak about your PhD training program, Dr. Sinem.
Thank you very much. I'd like to start off by thanking the IAH, especially the Educational Committee, for giving us this opportunity to be able to present our program. And so we're going to be discussing a different training model for adolescent medicine, and that is our PhD program at Hacettepe University in Ankara. So we're briefly going to discuss with you the need of adolescent medicine, of a doctorate program in adolescent medicine in Turkey. I'm then going to go on to discuss with you the history of the program and its aims. And then I'm going to pass the microphone over to my colleague, Dr. Kızılkan, and she's going to talk about, she's going to give you some more information regarding the program, such as where students are trained, what requirements are necessary, how students are evaluated, and what's needed to complete the program. And then I'm going to conclude with discussing the importance of the program. So as everybody here listening today is very well aware, there is a great need for more adolescent medicine training. And it's only by developing a more expansive and competent adolescent health workforce is that we can provide more opportunities towards addressing health needs of youth globally. We can go on to the next slide. So currently, I apologize, my camera. Okay, so Currently, there is no. Okay, so currently there's no formal training in adolescent medicine in Turkey, which means you can graduate from medical school without receiving any specific training or lectures in adolescent medicine. And this was also the case for residency programs in both pediatrics or family medicine, internal medicine, OBGYN. I'm afraid we have no formal adolescent medicine training, but Turkey is a very culturally diverse country, and over half of our population is under the age of 25, which means about 23 million adolescents in our country, which is actually higher than the population of some countries altogether. And our fertility rates remain very high, showing the great need of investment in adolescent health education. So when we look at how adolescent medicine started in Turkey, we didn't actually start off too bad, because when we have a look at the adolescent medicine clinics in the world, the first clinics were founded in the States in the 1950s and 60s. And our first clinic was actually founded here at Hacettepe University in 1965. So although we started off really well, I'm afraid this didn't continue, because adolescent medicine is still currently not recognized as a subspecialty in Turkey. So any physician who is actually interested in pursuing subspecialty training had to be trained abroad, which meant a scarce number of physicians were able to develop and deliver adolescent medicine services. And these were only in two major urban centres, one in Ankara and one in Istanbul, for many years. So to meet the needs of both youth in our country and also physicians who are interested in giving a more adolescent medicine prospective healthcare, a doctorate programme was established in 2004 at the Institute of Child Health at Hacettepe University in Ankara. So here in this photo, you see the pioneers of adolescent medicine in our country. These are our mentors, Dr. Orhan Derman, who I believe is listening here today, and Dr. Nuray Kambur. They were actually the founders of this program. And I'm now going to pass the microphone over to Melis, and she's going to discuss more about the aims of the program.
Thank you so much. And before I start, I also like to thank you so much for the IAH Education Committee, and especially Dr. Richard Churchill for making this symposium happen, and also including us, because this program means a lot to me. And I would like to share now the aim and content of the program with you. So as you all know, caring for adolescents requires distinct and specialized knowledge and skills, and therefore, adolescent health education should be a part of every health professional's education, especially the ones caring for adolescents. But when we look into Turkey, like Professor Akgül previously mentioned, this area is little less known to the physicians, and therefore they're generally not very well aware of the specific risks adolescents face throughout their transition. Therefore, the main aim of this program is to enhance developmentally appropriate care provided to adolescents in Turkey. So we know that there are certain differences between clinical training versus research training, as PhD trained people engage in the generation and dissemination of knowledge. And when we look at from this perspective, this stands a little bit in contrast with the role of clinicians, because clinicians primarily engage in the application of clinical knowledge to meet the needs of patients. So this program should have a balance between the clinical and research training. And this is why it's designed to offer a blend of clinical care education to patients and also clinical research training. With the clinical care education, what it aims for is to equip its students with the practical skills and knowledge so that they can deliver developmentally appropriate care towards their patients. And with the clinical research training, what it aims for is to involve its students to the scientific development area. So how does this program do this? It offers clinical practice hours in an adolescent medicine clinic. It offers courses and lectures providing adolescent health education. And finally, it offers academic and research training enhancing the development of new scientific knowledge. And with 3 of these areas, what it aims for is to produce well-rounded professionals competent in diagnosing and treating adolescent health issues and capable of contributing to the ongoing body of knowledge. So the primary training site of this program is the Division of Adolescent Medicine at Hacettepe University. And there are also other sites like the Departments of Obstetrics and Gynecology, Child and Adolescent Psychiatry, Dermatology, and Orthopedics and Sports Medicine. In order to enter this program, you need to complete a pediatric residency program because currently in Turkey, adolescent medicine is accepted as an advanced training in pediatrics. But we know that in different parts of the world, you can do adolescent medicine after internal medicine residency or family medicine residency. But what we hope for is to achieve this in the following years. And also there is a documentation process that you need to have an ALES exam, a foreign language certificate, at least for reference letter, and the graduation transcript. After this documentation process, then you need to complete an interview process with the Departmental Admissions Committee. Here are the general requirements of the program. You need to have 4 years of continuous clinical practice at the adolescent medicine clinic that you need to attend at least 1 day a week. And then 2 years of courses and coursework divided into 3 separate semesters that you need to take, again, at least 1 day a week. And this is separate from your clinical hours a day. And you need to complete a total of 240 credits in total. And these credits, among them, the 30 should be at least per semester. And again, you need to complete a certain amount of requested clinical practice hours per semester. The students are evaluated at the end of each semester through examinations for each course taken. And after the 4th semester, which is for the preparation for the doctorate sufficiency examination, you take a written and oral exam. And after that, there comes the dissertation proposal. And throughout about 2 years of time, you are evaluated for 6 monthly time phases to ensure the student has made good progress towards the completion of degree. And finally, you have your defense of dissertation. Here you can see the semesters and compulsory courses you need to take through each semester. And the 4th semester is for the preparation for your doctorate sufficiency examination. And here you can see the content of the basic concepts of adolescent health course. Here is the growth and development in adolescents. Here is the common issues during adolescence, nutrition and eating disorders, adolescent gynecology, and finally, adolescent mental health. And here are the elective courses. These courses can be taken outside the department. They're not mandatory, but highly recommended. And you need to take at least some of them to ensure you complete your credits. And in order to complete the program, you need to complete all your courses. You need to complete your doctoral dissertation. And finally, there is a publication requirement that means that you have to publish at least 3 papers around your thesis topic. And this also gives you the opportunity to graduate with the Orpheus degree. And here I give the floor back to Professor Akgül to discuss the importance of this program.
As again, everybody here is very aware that there are many challenges to further develop the field of adolescent medicine at an international level. And similar to Turkey, there are numerous countries that have restricted health budgets and few economical resources to fund adolescent-specific services. So until adolescent medicine is a subspecialty in Turkey, we believe that our unique program provides physicians with extended postgraduate subspecialty education in adolescent care. And we believe that it can potentially serve as an alternative model for countries who, similar to us, have yet to establish an adolescent medicine fellowship program. Now, here in this, this is a map of Turkey, and so here the black stars show the 2 institutions that had adolescent medicine clinics before the PhD program was established. Now, in this second figure, what we see is the black stars are now showing all of the adolescent medicine clinics that have been formed after the PhD program. And these are all students who were PhD trained in our program, have then gone on to form their own clinics. And in this third figure, you can also see that there was only one institution with a PhD program. Now we have 3. The other one that's formed in Ankara was formed by a student of ours who was the first graduate of the second graduate of the program. And then we also worked with the team in Istanbul to help them. They used our program as a model to form their own division and PhD program. So the program has achieved to train physicians to be able to give high quality healthcare in adolescent medicine in environments that are age specific, and youth are getting services strictly designed to meet their needs. We're also enabled, the program has also enabled us to give care for youth with more complex problems unique to the adolescent period. The trainees that we have trained have then gone on to train both medical students and residents in their own clinics. And so it has provided a dissemination of knowledge. And also Melis mentioned that there was also a publication requirement of the program. And so this has also contributed to scientific advances in adolescent medicine by increasing the research. So I'd like to end by thanking our mentors and the founders of our program, because they didn't give up. They were told many times by the Ministry of Health that there wasn't a need for any adolescent medicine training in our country. They were told that it would never be possible, but they never backed down, they never gave up, and they found a way to ensure that adolescent medicine training is possible in Turkey. So I'd like to use this opportunity to thank Dr. Derman and Dr. Kambur again. If there's anybody who wants to do some further reading about our program, we did actually publish a paper in the International Journal of Adolescent Medicine and Health in 2015. And here you can get some more information about the requirements of the program and what it has led to. So, and I'd like to again thank everybody here listening. I'd like to again thank the IAH and the Educational Committee. And here you see a picture of Hacettepe University, and the yellow arrow actually shows where we are today. So we are actually at the Adolescent Medicine Division at Hacettepe University currently, and the yellow arrow is showing where we currently are. So thank you again for listening, and we'd like to be able to answer any questions, or if anybody has any comments, we'd love to hear them.
Thank you so much, Dr. Sinem. That was a fantastic presentation of really an innovative program. So there are a few questions which our delegates have asked. So one of the questions says is that you started in the 1960s in for adolescent medicine in Turkey. And can you tell us, why is it still not recognized as a specialty?
So, the first clinic was actually founded in the 1960s, but it has taken a long time to be able to have the Ministry of Health accept adolescent medicine as a subspecialty under pediatrics. So although it started off well, as I said, there were only actually 2 adolescent medicine specific clinics in the whole country, one in Ankara and one in Istanbul. And one of the reasons is because there's no areas of training, well, there wasn't any before the program, there were very few adolescent medicine trained physicians. And so that meant that there were only very few clinics in the whole country, because nobody was specifically trained in this area. To be able to if you wanted to do adolescent medicine, you had to be trained abroad. And that is very, very difficult. We were very lucky. The first 3 of us, we were trained. Dr. Kambur was trained in Canada, and Dr. Derman and myself were trained in the United States. But this is very difficult, which only meant there were only a few of us, and that meant that adolescent medicine divisions could not develop. But we hope with this program, now there are more people trained in adolescent medicine, that we are still working with the Ministry of Health to ensure that it does actually become a subspecialty under pediatrics.
So you have demonstrated tremendous resilience
We
in
have.
sustaining this program. So congratulations. And there's
Thank you very
another
much.
question which asks, how many PhD scholars do we have now in adolescent medicine from Turkey?
I think 12, I think is the correct, Melis, is that correct? I think there are 12 of us who have finished the program. And currently enrolled in our program, we have 5 students. 5 of them are now in the thesis part of the training, so the second part of the training. And we've also enrolled 2 new students that are going to start in October. And so by the next few months, well, by the end of the year, we should have 4 more students who have completed the program, and 3 students who will continue in our program.
Thank you so much. Once again, it was a wonderful presentation, and we wish you all the very best in ensuring that adolescent health is soon recognized as a specialty in Turkey. Thank you very much.
Thank you.
And now we go to the next presentation. The next presentation will be presented by Dr. Richard Churchill, and it talks about using trigger videos to enhance adolescent health in primary care. Dr. Richard Churchill is a retired general family physician from Nottingham, England. He is the co-founder and trustee of the UK Association for Adolescent Health. He is also the former associate clinical professor and director of clinical skills at the University of Nottingham Medical School. Over to you, Dr. Richard.
Okay, thank you. I'll just share my screen. I may just bear with me 1 second. Hopefully this will come. There we go. Good. So, thank you for allowing me to present this. And this is going to be a little bit of a contrast to some of the other presentations today. Rather than talking about whole program changes, I just want to share a little bit of experience I've had in using a particular type of resource. And hopefully this might stimulate you a little bit to think about how you use resources yourselves. But let me give you a little bit of context. First of all, for those of you who don't know, the United Kingdom has a primary care-led NHS, National Health Service, in which more than 90% of problems are managed solely by general practitioners and their teams. This means that most adolescent healthcare is also managed primarily in primary care and in general practice. Now, the problem with this, of course, is that when you're training healthcare professionals, doctors, only a small part of the training is ever given over to adolescents. In some medical schools, it's very limited, for example, at undergraduate level, and at postgraduate level, whilst it appears in the curriculum for training general practitioners, it is a small part. And therefore, we've always got this problem in a generalist setting of how do we create awareness, how do we create a workforce that really understands the problems. And more than 30 years ago, the Royal College of General Practitioners, which is responsible for the curriculum for general practitioners, set up a small working group, as it was then, of really people who were interested in the healthcare of young people, and wanted to advocate for improved awareness, training and practice. And so the main roles of this group has really been to lobby and to raise awareness of the problems and try to influence the curriculum, to run some training courses and events, not whole curricular events, but just give opportunities for GPs to learn. And remember, we're talking about 30 to 40,000 general practitioners here, so not a small feat. And the last thing, which is what I'm going to be talking about really, is about resources and providing things that can be used to get people talking about adolescent health, to get people discussing it, and so on. Now, we know that the main areas in terms of developing a competent health workforce are the attitudes, skills, and knowledge. And I would argue that actually it starts at the top. If you've got the correct attitudes, then the you're motivated to develop your skills, you're motivated to develop knowledge. And so I guess a lot of the work we've done in the Royal College of GPs Adolescent Health Group has been to try to raise awareness, to stimulate interest with positive attitudes, so that doctors are more willing to develop their skills and knowledge in this area. So that's our context, that's where we're coming from. Now I want to talk about trigger videos, and these were originally described for use in medical education back in 1972. And you may say, well, what's the difference between this and any other educational video or audio-visual resource? And really it's there primarily to stimulate learning, to stimulate discussion. And when it was first described, it was thought to be much more effective in addressing affective and attitudinal objectives, the ones I was talking about in a moment, designed to trigger emotional response in the viewer that then gets people thinking about some of the complex issues. And as you see there, helps learners confront their feelings and give them practice in responding to challenges. They are not intended primarily as a standalone instructional content. They're really part of a blended learning package, and they can be used in a number of different ways. And I realise as I'm speaking that many of you will use these. You might not term them trigger videos. You might call them other things, but I'm sure many of you are using this sort of approach in your educational programs. But I think it's quite useful still to reflect on their benefits. And having looked at the publications, having looked at the research, there's a wide range of research or descriptions of how these have been used in psychiatric training, anaesthetic training, surgical training. Recently, there was a publication about how trainers could use them in their own, developing their own training ability as well. But there hasn't really been anything published about their use in training people in adolescent health. Now, I'm going to describe three types of trigger video that we've used over the years. They are not new, and I'll say that now. These are things that we've used and developed over a number of years, but to give you an example of different ways of using them, again, really to stimulate your own thinking, how could these be used in your own work? So let's go back to the early 1990s, and Dr. Chris Donovan, who sadly is no longer with us, he was the chair of this adolescent health group, and he wanted to stimulate discussion about one of the biggest concerns that young people have, which is about confidentiality, or the concerns that if you went to see a GP, a general practitioner, your parents will be likely to find out about it. And he created 4 different short snippet videos. I'm going to show it now, show one now, just giving examples how simply confidentiality could be broken without doing intentionally. Let me just play this one. Hopefully you'll be able to hear it okay. There we go.
Don't forget the pantomime tonight, Doctor, will you?
By the way, did you manage to go and visit Mrs. Eccleston today?
Oh, I did, yes. I popped in to do a leg ulcer dressing. It's getting a lot better, actually.
Oh, good.
She's a real sweetie, you know.
Oh,
she
she's
talks
lovely.
about her husband and the war and everything. I've known her for a long time. And just as I was leaving, I said, you know the girl you had in your last on your list, the extra? That's her granddaughter. And I said to her, I couldn't believe how much Alison had grown.
Oh, you didn't.
Why? What's wrong?
So this illustrates very simply how, you know, we may recognise this sort of scenario that the practice nurse, as it was, had been to visit a patient, happened to mention that the granddaughter had been into the surgery. And this is a thing that young people worry about, and how inadvertently just the fact that somebody, a relative had been in, could worry a young person. And the idea behind this, the trigger video, was to get practice teams talking about how easily it was to inadvertently break confidentiality with young people, and how that might be a problem and how it might be addressed in the practice. So that was one example. We then wanted to think about how we could improve consultations with young people. And so let's move on to the next example I'm going to give you. This is something called Helping Establish Adolescent Rapport. We called it HERE. It was a produces a DVD, and I realise again we're talking old technology. Of course, these will now be available streamed, but this is how it was produced at the time. Now, what we did in this package was we had 4 young people who were briefed with an outline of the sorts of problem they were going to consult about. And then they went in with a GP, and we did a video of how the consultation might look. Now, what was different about this was we did 3 different takes of the consultation. And the first was actually very poor. And we wanted to give examples to people watching and GP trainees who might watch this, that actually it's very easy, that there are some common mistakes people make. The focus of all of the consultations was on sexual and reproductive health. One was primarily on asthma with some allusions to other things. So I'm going to show you a clip here that actually is some bad examples, and it's each of these snippets is taken from one of the videos. So I've just put a few clips together, and hopefully you'll see there's some perhaps not best examples of how to consult in these. Hopefully you'll spot them. Let's see.
Right, it's Emma, isn't it?
Yeah.
Okay. And Emma, you're by yourself today, yes?
Yeah.
I don't really like seeing 15-year-olds by themselves.
How are you? Gosh,
Okay.
it's a long time since I've seen you. Must have been about 5, I think.
Yeah.
You've grown. It's incredible. You look just like your mum.
Jason, you are a bit late for this checkup. About 4 months overdue
4
now.
months? Just have a seat, I just need to finish this one.
Okay, how can I help you?
And you would like to have some tablets for your acne?
Yeah.
Yeah, I mean, it doesn't look bad to me, but...
How are they, by the way, your mum and dad? They were away recently.
Yeah, they've come back.
Okay, and hopefully just gives you a little taster of the sorts of how badly to consult with young people, either by being patronising, by bringing their parents into the consultation just by the conversation, or perhaps by being dismissive of the young people's concerns. Now, the way this can be used, of course, is once a GP trainee sees this, they think, well, I can do better than that, and that leads into them perhaps trying out this as a role play. And it gives them a safe space. I can, of course, do better than that. And there are a number of different ways of using that. And we also improved. We did a second take and we did a third take where the GPs improved their consultation. None of them are perfect. And that's fine as well, because it gives plenty of scope for discussion moving on. We developed that one stage further, and again, we had 4 consultations. In this particular follow-up DVD we produced, we wanted to illustrate the longitudinal nature of general practice and the fact that you see people more than once in the setting in which we worked. And so we did at least two consultations with each of these teenagers. In this case, we gave the teenagers a role and we used ordinary GPs who did not know what the young person was going to consult with. It was a blind consultation. We just said, get on with it. Do it as you normally would. And of course, you get a mixture of some good examples of good practice and some that haven't worked quite as well. Again, it was a different way of looking at the stories, and told stories help to tell stories. I'll just play a little bit of a recording here.
Okay, how's life treating you?
Not good at all. I just can't get Ben to come out of his room. He's eating in there, he's not seeing his friends, he's doesn't talk to me properly, like physically, not just attitude. I mean, just mumbling a lot, and we've got over the control thing. I've given control of his meds to him because we discussed all that and got through it, but I don't know, there's something going on. He's not sleeping. I hear him pacing up and down, talking, muttering to himself at night, and I mean, I don't know what's going on. Can you tell the doctor, Ben? Can you tell him what's going on?
Okay, is this one of those times you feel better if your mum Went out
Oh,
reading for a
please,
bit.
please don't send me out because I just.
No, you can be.
I just need. I'm sorry. I will go if you want. I'm not telling you how to do your job, but I need to know what's going on. I need to know now.
Now, this is a story where Ben has had epilepsy as a child. He'd been on specialist care, but he'd been discharged from the specialists. He has difficulty taking his medication, and there's been a previous consultation about compliance and adherence to medication. But actually, this presentation is one about early onset psychosis. And it's a longer consultation, but actually to young doctors who've never seen presentation of early onset psychosis, it is really powerful. It's quite emotive, and with both Mum there and Ben, and really educational from that point of view. And these are just illustrations of some of the examples we've used. So trigger videos, how can they be used? Well, they can be used to stimulate group discussion. They can be used for independent learning, and all these packages we produce where you can look at these on your own. And it can be a stimulus, as some people have used, for problem-based learning. It can be a prelude to interactive role play. We've incorporated some of these clips in e-learning packages, and sometimes I've used them if I'm giving a lecture, just want to get a little bit of reality into that lecture, playing one of these clips. So an enormous number of ways you can use them, and you can discuss ethical issues, consultations, clinical topics, or complex decision making. They can be used in a variety of different ways. Now, I would argue that actually having young people themselves live in teaching is always the best way of doing it. Unfortunately, what I discovered over 30 years is young people grow up. So the young people I worked with 30 years ago when I started doing this sort of work, I found are now in their 40s. They're not as good for doing live things. So one of the benefits of using recordings is, of course, we've got them for perpetuity. Really important thing is if you're doing this sort of thing, it has to be authentic to the setting you're working in. And some people would argue that the clips you've just seen now look a bit old-fashioned, which they do, to be honest. But whatever setting you're working in, whichever country, whichever culture, it has to look like it really could happen like that. And then the setting, the people, we use real GPs, we use not particularly well-trained actors. It wasn't scripted, but all of these scenarios were based on real life. We produced them simply, low cost nowadays. You could use an iPad, you could record it, doesn't have to be high cost. It needs to look real. They need to be used. Think about how you could use them in different ways and incorporate different perspectives. All of these videos actually used feedback from the young people themselves. And then how might you disseminate them? We disseminated all these DVDs to every medical school and every GP training scheme. So I hope I've demonstrated that these are a powerful tool, rich stimulus, brings a teenager into the consultation, can be produced and distributed at low cost, and contribute to blended learning. So hopefully given you some food for thought. Thank you.
Thank you so much, Richard. I think all of us are very excited to see these videos. And yes, many of us would like to use these videos for training purposes. So we were just wondering whether these were available online, like on YouTube or otherwise.
No, they're not currently available. We have streamed them previously, but I suppose the point I would make is that really, ideally, they need to be recorded in the clinical setting you're working. The authenticity is most important. So there may be ways we could share some examples. That would be good. I can look into that. But I would really encourage people to think about things that work in their own setting and could be authentic, easy to record and use.
Okay, so you mean to say all these videos were recorded live with the patient's permission?
Well, they're not. The patients are teenagers who are acting a role. So these aren't real patients. Okay. And that's the only acting bit, but they weren't scripted. They were the teenagers are given, here's the role you want to play it as you would as a real person. If you were that teenager, how would it be? So it felt as natural as possible. The same with the GPs, except in the first example there where we said do a bad example, we said to them, just play yourself, do it as you really would, because that has that element of authenticity, which would look different in different cultures, different countries with different ways of consulting.
Thank you so much, Richard. I think you have motivated us to use this innovative method of education. And I also noticed there was a feedback from the adolescents. So while you're using this training program, you're actually meaningfully engaging with them as well. Thank you so much. And now we move to the next presentation. The next presentation is to be on development of a module in adolescent health for medical students. It would be presented by Siska, and I have already introduced you to her before, and she would be joined by her colleague, Deanna. Deanna is a gynecologist and currently a PhD student with focus on adolescent pregnancy. And she too is the founder of the Indonesian Adolescent Health Association. Over to you, Siska and Deanna, to speak on development of a module in adolescent health for medical students.
Thank you so much, Preeti. So let me share my screen. Diana, thank you, Diana. Okay, this is the development of a module in adolescent health for medical students at Universitas Pelita Harapan, where we both work as a lecturer. Slide. And this is again the same archipelago map, but with different statistics. So we have 93 medical schools, both public and private, and we produce 10,000 to 12,000 physicians annually. However, as mentioned before, the pre-service adolescent health education and training is still very limited. Slide. And I would like to visit the need assessment that we've done in 2018. Most of our medical students felt that they had low self-efficacy in dealing with adolescent patients. They thought that adolescent health education in medical school was insufficient and it should be taught at medical school, and they were interested to participate in an elective adolescent health course. Slide. Before I talk more on the adolescent health elective course that we had separately, I would like to share with you how we construct the adolescent health in medical school at the core curriculum of our medical school at UPH. So we have it both in the preclinical and clinical year. In the preclinical year, there are 3 blocks that involve in adolescent health teaching. The first block is the reproductive health and growth development. We already had the puberty lecture, but we added some more understanding of the neurodevelopment part in it. And of course, we added the adolescent health lecture since 2016. And for the clinical skill block, we had history taking and physical social screening skills to 2017. And we also have a lecture on integrated management of adolescent health care. This is the Adolescent Friendly Health Service National Clinical Guideline for primary care from our Ministry of Health. And the last one, we integrated adolescent health issue into all related specific subjects within the introduction to clinical medicines block. For example, the nutrition disorder in children, previously it was only discussed about malnutrition in under 5. Now we already include anorexia nervosa and obesity in adolescents. And for clinical years, we only have it, but still only in the pediatric and OBGYN clerkship, because I myself as part of the pediatric department and Diana is part of the OBGYN department. Slide. And the elective course is 1 full month semester. It's for the students of the last semester of preclinical years, and we have the class is once a week for 100 minutes. This course involves 6 departments: pediatric, OBGYN, psychiatry, dermatovenerology, surgery, especially orthopedic, and medical rehabilitation. Right? And these are the competencies that we aim for our students: basic medical knowledge, medical legal aspects, effective communications, clinical skill, and management of adolescent health problems. And basically, this is how we construct our program. There are three main areas. The first area is about the basic knowledge of adolescents. This is mainly talking about the characteristic of adolescence, puberty, growth and neurodevelopment, and also social determinants of health. And the second area is about adolescents' health issues. Ranges from non-communicable diseases, sexual and reproductive health, mental health, addictions, adolescents with chronic illnesses or special needs, musculoskeletal issues, and skin health problems. And the last one, we have a phase of teaching the communication skill on how to perform open-ended questions, reflective listening, and psychosocial screening. But before doing that, we have a specific lecture on basic principle of adolescent-friendly health service. As the final project of this elective course, we required students to develop targeted advocacy material on adolescents' health issue as a group work. Sorry. And one of our mission is to have the future adolescent passionate physicians, yes, to work further with adolescents' health in Indonesia. So we try to make the program as fun and as engaging as possible. And this is, we started in 2020, yeah, when the pandemic struck. So we had it as an online program initially. It consists of interactive lectures, group work, and guest lectures, skill briefing and practice, mini OSCE for counseling skill, and also a virtual visit to National Best Adolescent-Friendly Health Service. Right. And we tried to make this pandemic situation, so we tried to take the most benefit of these situations since it's fully online, so we can invite adolescents from other parts of Indonesia, yeah, to give the students the experience of engaging with patients from different social demographic background, and also to have more, voices from the other parts of Indonesia. So this is also as a form of adolescents partnership, yeah, adolescents involvement in this program. And we also invited the Ministry of Health to share about the national program on adolescents' health, because it's easier when it's online, of course. And also we invited external experts. Yeah, once we invited Professor Susan Sawyer, and the other year we invited Dr. Tia Garita Nafisa from Malaysia. So it's really we can make we can have much benefit from this online situations, right? Okay, and we also had a chance to share a sharing session from the community of youth with cancer, which is located quite far from our school. So this is also the benefit of having this online course. And slides, and finally, we also had a virtual visit to one of the national best adolescent-friendly health service, which is also quite far from our school. Right? Yeah, and this is how the students express, yeah, their thought about the course, yeah, when we did our first adolescents course. Yeah, the majority thought that it was fun, exciting, interesting, and they got new insight around adolescents' health, which is quite different with the learning experience that they had before. Over to you, Diana.
Yes, thank you, Siska. So, as you can see, we had fun with our online programs, but then the pandemic stopped, and we're very happy with that, but we had to change several things. So we tried the offline programs. So the lecture was turned into group works, reading assignments, group presentation. We had a movie review, some games, also some lectures. But also we invited some real adolescents to practice with us. And we had a mini OSCE, and we have a real visit to adolescent-friendly health service, but only what's available around our university. And at last, we still have this project presentation. So these are the group work and presentations. We had fun with some games, and also like Dr. Richard said, we also have a video of us doing role play. And during one of the sessions about social determinants of health, we asked the students to watch a movie and then made a movie review. So we had quite fun, also role play for the communication. And for student assessment, we had 2 assessments. First is the skill evaluation, which is individual assessment about communication skill, about psychosocial screening skill. And the final examination is the final project presentation. And this is actually a group work, and it is commented by external expert panel review. And it was published on social media of Replica. Replica is our medical student organization focusing on youth health. So these are the example of the final projects. We have several topics and aim to different people. Like these are for the parents and teenagers about body image, and this is for teenagers about how to prevent risky sexual behavior, and this is about parents' role. So we had infographics and also some videos. So for the program evaluation, we are doing this quantitative and also qualitative research. First, as quantitative, we had a survey for knowledge and attitude before and after the program. And for qualitative, we had open questions on their thoughts and suggestions for the program. And I'm going to share you some video on the visit to the Adolescent Friendly Health Service and our primary health care. So thank you for watching the video. So if you ask me whether the offline or the online session, which one is more exciting, I think both are exciting, and we have different experience in each sessions. So thank you for listening to our presentation. And here is the beauty of Indonesia from West Java, the white corridor from where my hometown is. And if you do have any questions or comments, you can send an email to us too. Thank you. Over to you, Dr. Preeti.
Thank you so much, Diana. That was indeed very joyful. And I'm sure we all are filled with happiness. So I'm sure all of us agree that these were 4 fantastic presentations. We thank all the presenters, Siska, Diana, Sinem, Melis, and Dr. Richard Churchill for giving us such important insights into adolescent medicine and the way programs can be planned, implemented, and evaluated. You have seen that the programs ranged from the undergraduate level to the postgraduate level to the postdoctoral and also for the practitioners. We have seen in depth the content of the program and how they could be made fun, exciting, evidence-based, and engaging. Let's all collaborate and partner, learn more, and do more in the best interest of adolescent health. We also welcome you to join us for the next training programs by the IAH today in a few hours, and later on 15th November, we have 2 more programs. We hope that you would come and join us in this innovative discussion for improving education and training in adolescent health. Thank you very much.